then there's that guy who wants to do a full head transplant. Yeah, I forgot about that. He apparently had a successful operation on monkeys, where he transplanted the head up one monkey onto a different monkey's body, and it was successful. The monkey lived. And this is supposed to help in treatment with patients who have like ALS and
Alzheimer's or complete vegetative state. Now, did the monkey behave like whatever the brain was, or
I have no
the
idea.
body?
I didn't read the full article. I just saw a glimpse of it. I was like, this guy's crazy. Because majority of the medical world is saying that this is highly unethical. I mean,
Unless you tried, you don't know what is, like what is the result.
right.
Yeah.
And there's actually one guy who's willing to do the surgery. Like one guy with ALS. He's like, he has like maybe years left to live or 10 years left to live or whatever like that. He's like, I'll go for it. He's like, I'm gonna die anyway. I might as well just try it, right? So the plan to do human surgery, I think, is in about 4 or 5 years.
That's amazing.
That's crazy.
I'm all up for that. Wow, that's crazy. Wow. I wonder, so that'll prove a lot of things, man. So to see where most of the information is stored, like would the person behave like whatever the head is or the body, that would be crazy. The memories and the conflictings, that's something to look forward to, actually. If it's successful, though. Wow. Okay. Wow, it's 11. I didn't even realize.
11:15.
15 more minutes. Okay, let's do this. Let's start with the liver. No, as soon as I finish liver, we're good to go. Yeah. Once you finish liver, then we have nothing else left except colon. For colon, there's colorectal cancer, there's diverticulosis, there's those. We can do them on Tuesday, the first hour, and then we'll switch to. Now the thing is, guys, for Tuesday, we will start with immune system and infectious diseases. I don't know if I should go over each bacteria. You do have to memorize that, guys. Yeah. I think all I'm going to do is give you the basics of bacteriology, virology, how things work, the basis. But individual bacteria, I'll give you groups. I don't think I'll spend more than 2 hours on infectious conditions. And then I'll go to immune system. I have to spend time because there's a lot of physiology involved. Okay. Okay. Now when it comes to liver, the basic unit of liver is known as lobule. If you understand the lobule, you understood liver. Okay. Let's see, I'll try to draw it. I looked online for some pictures, but none of them were, good enough to explain a lot of things. So let's see if I can do this. First of all, I think I can erase this so I can just draw the lobule. Lobule is usually in a hexagon shape. This is imaginary. It's not truly, like you can see the pattern actually. When you look in the microscope, you'll see this pattern. In the center of the lobule, you will have central vein. Central vein. Let me make it bigger. Obviously, if this is central vein, this carries blood away from the liver. So it'll carry blood away from the liver. Okay. In the each corner of this lobule, this whole thing is called lobule. Just how we have nephron, which is the basic unit of kidney. The basic unit of liver is a lobule. If you understand one lobule, you understand the whole liver because it's repeated over and over. You know the portal triad, right? So, corner of each lobule, you should have a portal triad, meaning portal veins here, 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 and here. Okay. Portal vein eventually gives you branches to drain into central vein. Okay, that's portal vein. Let me do red, which is hepatic artery. Hepatic artery. I should have something. Let's make the purple slightly bluer so you could see the difference. Is that better? Can you differentiate? Is it me losing my eye color? Okay, there you go. The hepatic artery will also give you branches that will join eventually. Now it's not direct joining, so these are called sinusides. Sinusides is just like a plain field with water, like a lake, where fluid can mix in this area. So let me see if I can use this. So there will be a mixture of these two fluid. Slightly purple because it's full of nutrition. It's slightly deoxygenated blood, whereas from the artery it's completely oxygenated blood. These bloods will mix and eventually drain into what? A vein. I mean, very good. You know, it's common sense that blood coming from arteries will come to liver, be used. It will take oxygen, so this will give you just simply oxygen, and the portal vein will bring you nutrition, carbs, and amino acids and vitamins and stuff like that. You see the direction of flow is now in this direction, in these two, and eventually through a vein. But now portal tride also has something called bile duct. Bile duct actually don't drain. They start from here. Okay, they'll start from here. So bile duct receives stuff from hepatocytes. So the direction of flow should be in this way, opposite of everything else. And this, so you will have same thing. So the same triad should be in each corner. I'll just quickly do that just to show you. Okay, so the same triad. In the center, central vein. Now between these, so let's say you have also the same thing, just to make a picture so you can make sense. Right here, so between them you will have hepatocytes. Between these guys there will be hepatocytes. So let's say there's one hepatocyte, there's another hepatocyte, there's another hepatocyte, and these are the hepatocytes between them. And again you will have the veins and so forth going from here like this. So there's a lobule, and in the center you will have hepatocytes. Between all of these you will see hepatocytes. So group of hepatocytes are segregated like this. Okay. Now what I want to show you, so cirrhosis should make sense based on that. Hepatitis should make sense based on that. All these hepatic diseases, if you know this, should make sense. So these hepatocytes now, of course the hepatocyte will receive carbs and nutrition from portal vein. So from portal vein these things will go in here and will be processed and sent. And from the artery they will get the oxygen, but hepatocyte will secrete cholesterol, bile acid, bile salts, bilirubin into bile duct. And bile duct will carry it away. Okay? So that's the basic physiology or histology of hepatic lobule. Hopefully you can remember that. Now, let's say what is the function overall. What is the function of hepatocytes? So I'll erase this and I'll just keep those things so I have more room. What is the function of hepatocytes? What do hepatocytes do? Okay, in terms of metabolism, gluconeogenesis. Okay, anything else? Glycogenolysis. So much glycogenolysis, storing glycogen. So let's just keep it that way. Glycogen. So glycogen storage. Anything else?
Detoxification.
Very good. Let's include that on this side. So the P450 system. P, and I want to show you that in each of this, when there's a defect, you will have a specific disease. So abnormality of P450 system. Okay. Anything else? Very good. So let me let's go here, see, hopefully I can. One of the important function of hepatocyte is it causes bile acid synthesis. It produces cholesterol. Okay, what else did you say? I think you meant plasma protein as well, right? Plasma protein. Bile acid, bile salt, cholesterol, anything else? Clotting factors, unbelievable. Clotting factors. If there's clotting factor, there should be something else, other protein. You know what, I'll keep it under plasma protein. How about that? Let's keep it simple. What are the plasma proteins? Albumin. Clotting factors, you said? Anything else? Complement. Anything else? Anything else?
Infant producing RBC.
Huh?
Infant producing RBCs.
RBC, yeah. So in infant, you know, it initially starts with yolk sac, switches to liver, and then to bone marrow. Yeah, so the organs that are known as reticular endothelial organs includes liver, lymph node, spleen, bone marrow. All four of them are capable of producing RBCs and white blood cells. But in adults, it switches primarily to what? Bone marrow. Yeah. So plasmin or plasminogen. These are some proteins. Okay. In terms of detoxification, P450 system, what does it detoxify? Ethanol, estrogen, and let's say medications, in this case, drugs. Ammonia. So ammonia is not P450 system, so I'll include here mitochondria, right? Mitochondria, so ammonia. Okay, so anything else? Okay, good enough. If we can relate this. So number one, let's talk about cirrhosis. Now cirrhosis means complete destruction of portal triad. Portal triad is this bile duct, green, red hepatic artery, and portal vein. This is called portal triad. So in cirrhosis, these portal triads are completely destroyed. If it's destroyed, and the hepatic vein is destroyed, and this is replaced instead of these, all this is replaced with what? Collagen. So portal triad are replaced with collagen. Collagen is tough, non-living, residual protein. So there's nothing that can diffuse through it. It's water insoluble, which means what? If you have this problem, literally in cirrhosis means the big deal is, one, hepatocyte cannot produce none of these products. Number two, nothing can pass through here. So there's an obstruction of bile flow, of venous and arterial blood flow. So if there's an obstruction, this will lead to portal hypertension. Portal hypertension. Number one thing you should always think of cirrhosis, complete destruction of hepatocytes. The architecture of lobules are destroyed. They no longer look the same thing, which means there's an obstruction to bile flow and blood flow through liver. Now, if there's obstruction to, for example, remember bile has to, bilirubin is coming from where? From arteries. So this cannot come into liver. Therefore, stop piling up where? In arteries, in blood supply. So it'll give you jaundice, pruritus, dark stool, light urine. Dark urine, light stool. Right? So that's because obstruction of bile flow. But also this will give obstruction of portal vein and hepatic artery. Portal vein obstruction leads to what? Esophageal varices, hemorrhoid, and what's that rash, the purple rash on the abdomen of cirrhotic patient? Starts with a C. Caput medusae. Very good. And that's simply what? Paraumbilical veins. So you should know from anatomy anastomosis of porocaval system. portal system and vena cava system. There's one between the inferior rectum vein and superior rectal vein. And there's another one which will give you hemorrhoids. And there's between left and right gastric arteries, which will give you esophageal varices. And then you have perumbilical veins, which will give you caput medusae. So look for those things. So portal hypertension will be a cause of those hemorrhoids, esophageal varices, and caput medusae. Good. So we're done with that. Cirrhosis. Cirrhosis is equivalent of hepatic failure. So now, if you're unable to make cholesterol or transport cholesterol into the liver and metabolize it, that means you will have hypercholesterolemia. So cirrhosis puts patient at risk of hypercholesterol. Clotting factor not produced by liver is which one? 8. So other than that, all of them are produced by liver. So this will lead to tendencies of bleeding tendencies, easy bruising, easy bleeding. Complement prevents against capsular bacteria, or I shouldn't say capsule, sorry, gram-negative bacteria that have thin walls, especially Neisseria, gonorrhea, and meningitis. Okay, so you'll have increased infection in Neisseria bacteria in this. Epiprotein. What are epiproteins supposed to do? Carry lipids and plasma. Now, number one, you don't have epiproteins. Number two, you cannot get rid of cholesterol. Now you have a lot more free cholesterol. Puts you at risk of atherosclerosis, stroke, MI, aneurysm, and so forth. Plasmin. What does plasmin do? Plasminogen is a zymogen, and plasmin is the activated form. It's supposed to break clots. Okay, it's supposed to break clots. That means plasmin can start digesting. So number one, no, you don't have clots. That means there is no clotting. That means there's tendencies of bleeding. Plasmin also increases tendencies of bleeding. So the bleeding tendency will quadruple now. Okay? You don't have the things to seal the cuts, but you have a thing that to make those cuts. Plasmin, because it's a protein will start digesting stuff. Huh?
It would decrease, right?
Plasmin? Plasminogen will decrease, but activation of plasmin increases. Yeah, because there's plasma that's produced by endothelium too. So yeah, you're right. The liver will decrease, but the endothelium plasma will increase. So the and special plasminogen inhibitor, I should have put that plasminogen inhibitor. This is the one that usually will decrease. So bleeding tendencies will decrease. So this is more appropriate. Plasminogen inhibitor will decrease. So as a result, bleeding tendency overall will increase. Yeah. Okay. And of course, if you cannot do gluconeogenesis, this will lead to hypoglycemia. Now coming to mitochondrial damage in the hepatocytes. If it's hepatocytes are damaged, that means they cannot do what? Convert ammonia to urea. As a result, you'll have hyperammonia, and that gives you confusion, lethargy, all that stuff. P450 system, the most important one is estrogen in this case. Of course, ethanol, people are alcoholic, number one cause of cirrhosis is alcohol, but estrogen in men is not metabolized. Okay, so now you have too much estrogen production, and that can lead to gynecomastia. So overall, the symptoms of cirrhotic patients should be edema or ascites, okay, because of albumin problem. Too much cholesterol, that puts you at risk of because of ammonia. And you will have bleeding tendency because of complement problems, okay, and or plasma protein problems, increased risk of infections. Overall, that's what cirrhosis will do. Now, what I want to talk about is, at the end, what is the risk factor for cirrhosis? In North America, number one, the risk factor is alcohol, alcohol, alcohol. Not 1 day, not 2 days, chronic alcoholic intake. The second most common cause is hepatitis C virus. Hepatitis C virus is RNA virus, RNA positive sense RNA virus, enveloped, and it causes hepatocellular carcinoma, and most common cause of hepatitis overall, chronic hepatitis. That will lead to cirrhosis, cirrhosis to cancer. You have to know that one. And the way you get hepatitis is mostly through blood transfusion, or blood contact, or somehow plasma mixes with somebody else's, needle sharing and stuff like that. Okay. So cirrhosis, you have to know that. All the symptoms of cirrhosis, physical signs and symptoms of cirrhosis, always make sense. The question is, how would you test for it? You do have to take a plasma sample. In plasma, what do you have to find? extra cholesterol, extra bilirubin, and AST and ALT. Now, when it comes to liver, you have to remember that there's two types of tests: functional test and structural test. A test that determines the functionality of liver. Can it do its job? You know, the job of liver, for example, is to get rid of cholesterol. The job of liver is to make bile acid excreted. The job of liver is to conjugate bilirubin. So if you can't do that, if you find hyperbilirubinemia, hypercholesterolemia, increased bile acids, for example, in plasma, that means functional problems. But if you have increased AST and ALT, that means structural problems. That means what? Liver cells bursted or lysed or ruptured. The only way you can have increase in plasma of enzymes that should be locked in within hepatocyte is only if cells rupture. So when you have AST and ALT, it tells you structural defect in hepatocytes. But when you have increase in bilirubin and cholesterol, it tells you functional defect in hepatocytes. Not necessarily they didn't burst, it's just the enzyme are defective or the cytochrome P450 system is not working. So when you look for those things, you should be able to differentiate between structural defect and functional defect in livers. Okay, so look for those things. More than that, you should also eventually should do biopsy. Now the biopsy is when you have alcohol. What alcohol does, it causes obstruction of these ducts, and it causes irritation, and the irritation becomes chronic, and it recruits what? Macrophages. Macrophages in liver are known as what? Kupffer cells. These Kupffer cells will release interleukin 1 and interleukin 12. They recruit more fibroblasts. Fibroblasts exist in the spaces of DESI within the sinusoid of hepatocytes. Okay, space of DESI have a lot of fibroblasts, and what do fibroblasts do? Produce collagen. If you activate them, and one of the activator for them is what? Interleukin 1. So interleukin 1 is likely to activate fibroblasts. Superactivation of fibroblasts does what? Produce too much collagen. Instead of having the sinusoids, these veins, now they are replaced with what? Collagen fibers. And as a result, it leads to obstruction of bile flow and blood flow through liver. All the problems come from there. All the problems will come from there. So when you do a biopsy, you should see complete destruction of what? Portal triad. Biopsy of liver, you will not see portal triad. They'll be destroyed. In plasma, you will have increased cholesterol, increased bilirubin, and unconjugated bilirubin especially. Okay, all of these things should help you. Treatment is what? Based on condition, based on symptoms. The only solution, cure, is transplant. And again, you have to find a liver that's the same size, that fits in that area. If it's a small person, you cannot give them a large person's large liver. It won't fit in that area. In addition to that, you have to make sure that it is not rejected. So you have to match the transplant organ plus the size, and that's difficult. That's a liver transplant is very difficult. Okay, so you have to find two matches: size and immune matching, MHC1.
It won't grow if you put a small liver.
Hasn't worked yet. You can shave it off, but then again, that leads to itself fibrosis. Yeah. Yeah. It's a type of collagen
A certain type of collagen that gets formed.
that gets formed.
Yeah.
Oh, in this case, no, it's not known. It's usually probably collagen type 3 mostly, but there's no 1, 2, 1, 2, 4. It's usually 3 in this case. The predominant type of collagen. So that's for cirrhosis. So again, cirrhosis is straightforward. Whatever liver does, that's affected. Liver is supposed to... Okay. In Reye's syndrome, of course, again, adults are not affected by this because an adult liver is mature enough. It's usually in children when the liver is immature. Plus, not every child is at risk, especially those children who have some liver defects. Okay. Now, very good.
For fever during infection.
Yeah.
Viral infection usually?
Always viral. Upper respiratory infection treated with aspirin in children, usually 5 years old or in that age group. Now, when aspirin is metabolized, it produces toxic side products, And this product causes damage to what? Mitochondria. It's almost like apoptotic reaction or necrosis. So mitochondrial damage at the end of the day, end result is mitochondrial damage. And hepatic, very good. Have confusion, lethargy, headaches, maybe seizures, accompanied by light, star urine, jaundice, right upper quadrant pain of sudden onset. You have to think of this. Treatment of upper respiratory system or infection, especially viral. So whenever you in children, but it doesn't occur in adults mostly. It's always in children because their liver is not mature enough. It cannot deal with such a load of things. Okay, because if they have infection, that means liver is already working hard to produce these complements and these things. So now you use medication that is toxic to liver. It will cause a lot of burden on the liver. Yeah, it's reversible. The good thing is it's reversible. But it's known as acute hepatoencephalopathy, not chronic, acute hepatoencephalopathy, or encephalohepatitis. The end result is the same. Liver and brain are affected. And the brain is because of ammonia. Liver is direct damage from aspirin. Okay? So this will be ammonia in this case. But of course, we discussed in protein synthesis and urea cycle, the genetic parts. I'm not going to go over that. Urea deficiency, carbonyl phosphate synthesis 1 problems, or carbonyl phosphate ornithine transferase. You got to remember those things. You have to remember those things. Okay. So that's for this. Let's talk about a condition. Let me make this smaller. I don't think we need it anymore. Anyways, you know. I'll just have liver. So remember, in liver, we should have hepatic vein carrying blood away, and portal vein. Whoa. Portal vein bringing blood, hepatic vein carrying blood away. I always try to do the portal vein more purple because it's slightly oxygenated.
Lots of nutrition.
Yeah, very rich in nutrition. Let's talk about 2 conditions that can affect the liver. So, again, whenever you think of liver problems, always any disease of the liver, I'll give you 3 locations: A, B, and C. Look for those. 3 locations in liver will cause disease. There is nothing else to it. Pre-hepatic conditions, intrahepatic conditions, or post-hepatic conditions. Now, pre-hepatic is usually almost always hepatic vein thrombosis. Hepatic vein thrombosis. Do you know a disease that causes hepatic vein thrombosis?
A disease?
Disease or syndrome. Right? Okay. And then post-hepatic. No, jaundice is just physical appearance. Jaundice is not a disease. It's a sign. Yeah. Yeah. It's just skin discoloration. No. I'll go over this. Just once I go over it, if you still have questions, please ask me. Now, this is usually because of what? Stones. Okay, stones. In the case of what? Bile stone, gallstones. Okay, we're talking, portal vein. I should do 2 things. Sorry, let me just make one more. Sorry, stone will not make sense with the portal vein. So, post-hepatic are either bile duct obstruction or portal vein obstruction.
Portal vein hypertension.
Well, obstruction will lead to hypertension. Yeah. Okay, so most of these cases are either congenital, portal vein doesn't develop, or you have gallstones, which we have discussed before, or you have primary biliary cirrhosis, or you have primary sclerosing cholangitis. Okay, those are the 3 things. Now, here, the only thing you have here is Budd-Chiari syndrome, okay, which is hepatic vein thrombosis. Okay, Now, majority of the diseases are intrahepatic. Intrahepatic. Let's talk about some of these intrahepatic diseases. Two of them are extremely important and famous. Wilson's disease and hemochromatosis. Things that are kind of close.
Wilson's is copper deposition, right?
Very good. The underlying cause of Wilson is what? Copper transporter defect. Copper transporter defect, such that it transports a lot of copper into cells, away from blood. Okay? So it's copper deposition, right? And the hemochromatosis deposition of what?
Iron.
Iron. Very good. But both of them are genetic. Iron, what number is F if you count alphabetically?
6.
6. So it's on chromosome 6. The mutations located on chromosome 6. For copper or Wilson's, what do you think? 6 times 2? Okay. Chromosome. Yeah. Okay. Now, at the end of the day, it's nothing more than hemochromatosis. Osis always means what? Abnormal deposition. Too much. Wilson is copper deposition. Iron. Okay. All right. When it comes to Wilson's disease, now in Wilson's disease, we have to know that which organ are more likely to be affected by deposits of copper. What organ? And both of them are diseases of Caucasians. Caucasians. All the hemochromatosis slightly young population. Wilson's a little bit older. Okay. Now, in Wilson's disease, let's talk about the organs that are primarily in order. We must know the order. What do you think the order is in Wilson's disease?
Liver. Oh.
In hemochromatosis, liver first. Second is skin. Third is pancreas. And then you can have adrenals and pituitary. But when it comes to Wilson's, think hard. Think as much as you can. If you have no copper in the brain, you'll be able to think. Brain, CNS. We have basal ganglia first. And then frontal lobe. So brain first. And then eye. And then okay. So this order of importance will help you a lot. Which means in Wilson's disease you will always expect what? Neurological symptoms. Basal ganglia gives you what? Parkinsonism. So expect here basal ganglia, Parkinsonism.
Parkinson-like syndrome.
Exactly. Parkinson's-like symptoms. Always in Wilson's first. Frontal lobe gives you what?
Cognition.
Very good. Emotional is correct, cognition is correct too. But before that, yeah, sometimes you think it's someone else. Personality changes. Psychotic behavior. So psychosis. Very good. Personality change, psychosis. And how about eyes? What's that ring?
A golden ring, yeah.
There you go. You're correct. Caesar Flisch's ring. Okay. I think it's there's an S missing between C and I. You can add it. Liver, what would it cause? Let me change color so we can not confuse.
Deposition.
Yeah. So cirrhosis. Good. So you see, in Wilson's disease, the first thing you should always look for is what? Neurological problems. Physical signs. Ring in an eye. Now, the ring is not always the same color. It depends on the iris's color. If you have green eyes, it'd be a slightly different color of green. If you have brown eyes, more brownish color, like light brown, blonde sort of color. If it's dark eye, different color. So you don't always look for, because sometimes students, what they do is they memorize, because they've seen questions on UWorld or Kaplan or whatever, they always show you one picture which they copied directly from the USMLE questions that are available on USMLE's website, which is a blue eye. You won't always have a blue ring. No, no, no. Depends on the color of your eyes or that patient's eyes. Okay, as long as the ring will be different, it will be glowing slightly. Liver. In hemochromatosis, what do you expect? Cirrhosis first. And in skin, what would you have? There you go. Now we're thinking. Brown pigmentation. Isn't it called Brown's diabetes? So because pancreas will cause destruction of specifically endocrine cells. So it leads to pancreatic insufficiency eventually, but initially only endocrine cells, especially beta cells. So it'll cause diabetes. Lack of insulin production. Receptor is normal. Adrenal, what would it cause? Addison's or atrophy. Very good. Pituitary atrophy. What do we call a condition where you have pituitary atrophy? Acute pituitary failure in pregnant female. Lack of blood supply. Sheehan syndrome. But this is chronic. This is slowly progressive. Apoplexy means when there is pituitary adenoma and it ruptures and it starts bleeding in there. Yeah. But this is pituitary atrophy. What time? 10 years, so forth. Slowly. So that means female and men are normal until, let's say, 30s and something and beyond. They will start slowly have deterioration of LH and FSH. Now, when it comes to pituitary, what is the most important hormone of pituitary? Anterior. Ignore pituitary. See, posterior pituitary is actually just a storage. There's no blood supply. ACTH is the most important.
For cortisol, right?
Very good. Aldosterone is more important than cortisol. You can live without sugar, but blood pressure? Problems. Because aldosterone regulates blood pressure. ACTH regulates aldosterone as well. So that's one. What's the least important? Prolactin, LH-FSH, growth hormone. So the sequence is that the least needed hormone in their cells are affected first. So first, if it's pituitary atrophy, you will have infertility. Okay, in male and female, maybe. Or impotence in men. Okay. And then you will slowly go to lactation is never a problem because it's only once in a while, right? Only upon pregnancy. And then thyroid problem is second. And eventually cortisol and aldosterone problem. Okay. So look for those things. Now, the way to test for it is look for blood. In blood sample in Wilson's disease, what would you have? Increase? Copper. Now, it is usually very difficult to find copper as an electrolyte. Biopsy will be the best option. You will have increased copper storage in hepatocytes. So here, you have option of taking biopsy from the brain, basal ganglia, frontal lobe, eye, or liver. What would you do? Liver.
Since it regenerates.
It's easier, yeah. It's exposed and it's not so much damaging. So do liver biopsy and then you'll see hepatocytes full of what? Copper deposit. What happens to ceruloplasmin? What's that? Transport of copper in plasma. Transport of copper in plasma. Does it increase or decrease? Increase. Would it be saturated or unsaturated?
Saturated.
Very good.
If you have so much that it has to deposit itself, it means you have overload, right?
Mm-hmm. So in plasma, look for that. Now, when it also maybe you'll find in tissue interleukin-1 because it leads to chronic inflammation as well. Macrophages, recruitment and infiltration of hepatocytes. When it comes to hemochromatosis, what do you expect to find in blood or in plasma? Do you think iron is increased? Okay. Do you think transferrin is increased?
Yes.
Do you think ferritin is increased? Okay, so all three of them are increased. Good. Let's do one more. That's crazy one. Do you think transferrin saturation is increased or decreased? Transferrin saturation. Saturation. Yeah. If you have 6 people sitting in a single car, saturation of that car is increased, meaning it's occupied. Saturation literally means occupation, like hemoglobin saturation. Transferrin saturation means there's no seats available. Now, when we talk about total binding iron capacity,
Decrease.
that should be decreased because there's not much room empty. There's nothing available. Saturated things have less binding capacity. Unsaturated have more binding capacity. Okay? Okay. Eventually, in both cases, you have to do biopsy. Now, when it comes to hemochromatosis, would you biopsy of the liver, skin, pancreas, adrenal, and pituitary? Which one would you do? Skin. And what part of the skin would you take? The brown pigmentation areas. So you'll take a biopsy of that region, and then you find what? Iron deposit. What is a what is abnormal deposition of iron called? Let me give you clues. Lipofuscin, what's that? Lipofuscin. It's abnormal deposition of lipids. Now, mole, for example, it's abnormal deposition of melanin. Okay. How about, what did I say, iron? Hemosiderin. You heard of that? That's what I'm talking about. Yeah. Yeah. Okay. If you want to do anything, because I believe most of you have studied the difficult stuff and you know it well. I believe that because that's what usually happens. Don't ignore the simple stuff. Don't ignore the simple stuff. Spend a little bit more time on that because the exam is usually on simple stuff in a very tricky way. I hope I finish this in the next 2 weeks. When you go to questions, NBME questions, you will see. Because that's what I really care for. If you can score high NBME questions, I think you'll do really well on the exam. And I'll try to do as much as I can among those questions. So I think if you don't have any block, we'll get it. You guys will chip money together and buy it and screenshot it for me, and I'll go over it. But as far as I know, I have 1 to 6, which are no longer available. I have 7, I have 9, I have 11, 12, 13, 15, and 17, I don't know. I'll get it from some students. We'll go over those questions in class.
Amyloidosis all of that disease or no?
Amyloidosis, abnormal protein deposition, can occur anywhere. In liver, because usually proteins are used up, not so much. Mostly it affects vessels, especially kidney. Amyloidosis, when I think of brain, two places. Okay, so that's for Wilson's and so what we did cirrhosis, we're done. We didn't do jaundice, right? Let me do that again. Hemochromatosis, Wilson's, we did. Did we talk about Chiari? Rai, we did. But Chiari I didn't do in details. Rai, we did. Okay, let's do jaundice. Now jaundice, quickly, two things can happen. Jaundice is a problem. It's a complication of many hepatic diseases. You can have prehepatic, or you can have posthepatic, or you can have intrahepatic, blue intrahepatic. Prehepatic is usually always vascular. Prehepatic, and what is the cause of jaundice?
Conjugated bilirubin.
Bilirubin deposition. Now it could be unconjugated, or it could be conjugated. What's another name for conjugated and unconjugated?
Direct and indirect.
Direct and indirect. Unconjugated, indirect, conjugated,
Direct.
direct. Good. Where does conjugation of bilirubin occur?
In the liver.
In the liver. What is the enzyme that causes conjugation of bilirubin? How about this? Huh? UDP. That's correct. Partially, but you need one more thing. UDP, glucuronal transferase. Okay. Now, how about this? Very good. Very, very good job. Now, what is the source of bilirubin?
Hemoglobin.
Hemoglobin. Good. And if you remember, hemoglobin looks something like this, right?
Yeah, it's got that gigantic brain thing.
When I was 5, 6 years old, my mom had some diamond treasure like this. I broke it and I melted down and I made something new out of it. It always look like this. I still remember the design. You know, Afghan women, they will have this big chunk of silver and stuff. They'll put it on here and hook it here and here. I don't know, so a lot of those things. But I remember oh my God, I had to go with my grandma sleep for 2 weeks. But imagine you open this, so the center should be iron. First thing with bilirubin is you open this. When you open it, it should look like this. This is biliverdin when you open it up, when you open the ring. Biliverdin. Now, most of this it has double bonds. Now, we're not talking about globin part of it, heme only. So when you think of bilirubin, it's a byproduct of what? Heme metabolism. Heme. And when we go to RBCs, we have to know how to make heme and how to break it. I'll spend more time there. But know that it has these double bonds. It's mostly hydrocarbons. So it's insoluble in water to an extent. Whenever something is insoluble in water, it becomes toxic. It can deposit, especially in the brain. If unconjugated bilirubin deposits in the brain in children, it can cause mental retardation. And what do we call that condition? Starts with K.
What?
K. Yeah. K-E-R. N.
Connectors?
There you go. Okay, so far it's insoluble. Conjugation simply means what? You add glucose to it. It's actually glycosylation, what we call conjugation. Conjugation meaning putting two things together. So when you add sugars, when you add two sugars, one on each side, and this sugar is UDP glucose. UDP glucose. UDP glucose. It should be UTP, but the one phosphate is released to make the bonding. This is why it's called UDP, glucuronal transferase. You transfer UDP glucose into what? Into bilirubin, and that's what the enzyme is called. So adding these two makes bilirubin soluble. Now it could be cleared. So this is conjugation. Conjugation occurs within hepatocyte with the help of UDP glucuronidase or uronal transferase. Same thing. Okay. So we have two issues here. What if you are unable, for example, you break so much hemolysis, there's so much hemolysis that UDP glucose uronal transferase are not able to convert all of it at the same time. You have more biliverdin, you have more heme than the enzyme can take care of it. So this will lead to unconjugated bilirubinemia. All hemolytic anemias leads to what? Jaundice or unconjugated bilirubinemia. Unconjugated bilirubinemia. All hemolytic anemias. All hemolytic anemias. All hemolytic anemias. Can we name some hemolytic anemias? The top ones. You gotta know them, because this is how you should know this in the context of hemolytic anemias. Hereditary spherocytosis. Common in Caucasians, right? Spectrum deficiency. Sickle cell. Okay? Pyruvate dehydrogenase deficiency, very good. Anything else? Pyruvate, oh, yes. I thought I said that there were actually, I said pyruvate dehydrogenase, which don't exist. Glucose 6-phosphate dehydrogenase deficiency, very good. Anything else? Nocturnal paroxysmal hemoglobinuria, very good, excellent, excellent. Yeah, look for those things. And then you have autoimmune hemolytic anemias. Okay, so always you will have that. Now, hemolysis, the question usually will come. There are two types of hemolysis. Generally, what's the normal location of hemolysis? Spleen. Spleen. In the spleen, what breaks down RBCs? Macrophages. And they will only break what type of RBCs?
Worn down ones?
Old ones. Old ones, worn out.
They could be new, but if they're damaged, the macrophage will pick them up too, right?
Yeah, if they're not disc shaped, they're not flexible, like spherocytes, they'll get stuck. Okay. So, two types of hemolysis. Now, if it is extravascular hemolysis, that's done by macrophages. Intravascular hemolysis is done by who? Complements. So now, if the question of anemia comes, now I think Hulda mentioned nocturnal paroxysmal hemoglobinuria. Is that extravascular or intravascular? Intravascular, because you don't have glycoprotein I3. As a result, who attacks them? Complements. And they're supposed to inactivate complements, attack them more free radicals. Okay. But spherocytosis, extravascular, because they're large RBCs. They'll get trapped where? In the spleen. And they'll be attacked by macrophages. So know the difference. So number one, that's hemolysis occurs in blood. This will cause all unconjugated bilirubinemia. Unconjugated bilirubinemia will give you what kind of stool? Light color. What kind of urine? Dark color. Conjugated usually will not give you that. Stool will be normal, urine might be normal. Okay. And unconjugated bilirubin can be treated with what? Phototherapy. Phototherapy. Huh? Same thing. Yeah. With phototherapy, light. Now, have you heard of physiological jaundice? You know, on the exam there's a lot of normal things. Newborns. For how long would newborn have jaundice, physiological jaundice? 2 weeks is good, yeah. About 10 days. Yeah. And it should get resolved. It should get resolved. So, and that is especially, you know, like maternal milk, people who, especially children who are breastfed. The maternal milk is rich in fatty acids. And fatty acid will do what? Conjugate to albumin. And as a result, you don't have much albumin required to carry bilirubin. And bilirubin accumulates. But it will dissolve because eventually you'll get, your liver will mature enough, you will have more albumin and it will take care of itself. That's why it's only transit, only for about 10 days. Okay, so we're done with pre-hepatic jaundice. The majority of causes are what? Hemolytic anemias. Hemolytic anemias. Hemolytic anemias. Meaning the liver is overburdened with so much that it cannot conjugate it. Okay. Let's go to post-hepatic. A is done. Let's go to post-hepatic, which is much easier. Usually, almost always, it's obstruction of what? Bile ducts. But it has to be common bile duct or common hepatic duct, or both left and right ducts, or all of the small intrahepatic ducts. Which brings two things. Gallstone, we have talked about it, so I'm not going to go over gallstones again. Unless you have biliary atresia. You heard of that? It's lethal. Unless you do something about it. It's lethal. Biliary atresia means there's no bile being secreted from the liver. It cannot go past that. And that's jaundice upon birth. And a lot of problems. So it's lethal. So that's one thing. But we have two conditions. We talked about it earlier. Somebody mentioned primary biliary cirrhosis versus primary sclerosing cholangitis. There you go. Let's compare these two. Now, you can call them post-hepatic. You can call them post-hepatic, and they are. So in primary biliary cirrhosis, see, cirrhosis is not inflammation. Cirrhosis, look at the name, cirrhosis, and here you have angitis. Both of them are disease of what? Bile ducts. Bile ducts, especially small bile ducts. Cirrhosis is mostly intrahepatic. Cirrhosis is only intrahepatic ducts. Primary biliary cirrhosis. This is not alcoholic cirrhosis. This is not alcoholic cirrhosis. This is actually autoimmune. I'll tell you what the cause is. But I want you to make sure you understand. Primary biliary cirrhosis, only intrahepatic ducts. Primary sclerosing cholangitis, both intra and extra ducts. Okay, both ducts are involved. Now, the cause of primary biliary cirrhosis is antibody, and these antibodies are anti-mitochondrial antibodies. In primary biliary cirrhosis, the underlying cause, the one thing that can point out at, say, you are the one causing all of this, it is anti-mitochondrial antibodies. Anti-mitochondrial antibodies. Now, in primary sclerosing cholangitis, it's chronic inflammation of unknown cause. Therefore, you know, we talked about this earlier in the setting of Crohn's and ulcerative colitis. It's more associated with ulcerative colitis than Crohn's, but it could be in both because they have something in common. They're all chronic inflammatory disease, some similar to what you said about sacroiliitis. Okay, so same thing. But most importantly, it's associated with what? Ulcerative colitis. What do they have in common?
Inflammation.
They both have one common risk factor, hepatitis B virus. Hepatitis B virus, don't forget that. I had in my exam at least this one for sure. Hepatitis B virus is strongly associated with, and they will give you a choice of that. Okay. Now, here this is destruction by autoimmune, so it is the intrahepatic duct are diffusely atrophied. See, autoimmune inflammation leads to what? Atrophy. But non-inflammatory disease leads to swelling. Here you will see beaded appearance. So this is a duct. Parts of the ducts are swollen, parts are atrophied. Swollen, normal, or atrophied. So you'll have this beaded appearance under microscope. Okay, with primary sclerosing cholangitis. Okay, good. Look for those things again. Now, at the end of the day, no matter you have atrophy of ducts or you have swelling of ducts, what happens to the size of ducts? It shrinks. They become narrow. They go through stenosis. The absolute complication of that is jaundice or bile flow obstruction. In both cases, you will have bile flow obstruction. And when bile is not flowing through there, that means it will accumulate where? In hepatocytes and in plasma. So you will have conjugated bilirubinemia. Conjugated bilirubinemia. And that will lead to jaundice and that will lead to pruritus. And in addition to that, these patients will have chronic fatigue. Chronic fatigue. Usually they might not have right upper quadrant pain, but in primary biliary cirrhosis, they will eventually lead to cirrhosis. And you have to transplant. Okay? Now, primary biliary cirrhosis common in who? Females in their 30s and 40s. Sclerosing cholangitis common in who?
Yes.
Caucasians, teenage or 51 years old. Crohn's or ulcerative colitis. Okay? Testing for it is do ultrasonography, do CT scan, and also measure plasma content of ALT, AST. But the one thing that's most important differentiating this from liver problem is what? Alkaline phosphatase. Any duct problems, bile duct problems will increase in what? Alkaline phosphatase. Alkaline phosphatase. So AST and ALT is increased, but alkaline phosphatase by far more. But if you compare this to hepatitis, ALT, AST is increased more, and alkaline phosphatase less. So you always have to look at the ratio. Okay? Yeah.
Can hepatitis lead to either of these? Hepatitis C or hepatitis B?
B.
B?
Yeah, cholangitis. C leads to cirrhosis.
Mm-hmm.
Yeah. Okay. So that's for this. Treatment for both of them is you have to give them maybe prednisones or especially for cirrhosis, you can give them prednisones or methotrexate, something immunosuppressant. And for cholangitis, depending what it is, you have to do symptomatic treatment. Okay. So that's for these two. These guys are done. And this is done, this is done. So we talked about jaundice that is post-hepatic or obstructive. These are the two causes plus gallstones. Okay? These are three things you should look for. Unless you have biliary atresia in a question or in a patient, which is always inborn, which is always congenital. Yeah. Let's move on to intrahepatic issues. Intrahepatic issues. Again, extrahepatic, look, prehepatic will always give you unconjugated. Posthepatic will always give you conjugated bilirubinemia. Intrahepatic will give you both. Mixture of conjugated and unconjugated bilirubinemia. Okay? And you just think about it, like once you have so much knowledge, you just don't give yourself the credit. Just think about it. You know all of this. How you apply it is now the case. Right now you want to learn how to apply it. And the thing we have to discuss in intrahepatic is, what's the enzyme called that conjugates bilirubin? U-DP glucuronidase. or urinal transferase. So what I'll do is I'll use glucuronal transferase or gut. If this enzyme is deficient, now it leads to hereditary bilirubinemia, which we call Crigler-Najjar syndrome. If it's complete deficiency, it's Crigler-Najjar syndrome. What if it's partial?
Still, Crigler-Najjar syndrome?
Type 1 and type 2 is both, yeah. So you have two things. You have 4 conditions in this category. Gilbert, there you go, that's partial. So you give it right away. Good job. Gilbert. That is partial. So I'll say decrease. Oh, I wrote the name first. In Gilbert, this is partially deficient. It's not complete deficiency, partial. Okay, in Gilbert. Okay, so this is one thing. Now we're talking about intrahepatic cause of jaundice. If you have complete deficiency of the enzyme, Crigler-Najjar syndrome. If you have partial deficiency, Gilbert syndrome. What if you have enzyme is functional, but you cannot dump bilirubin into bile ducts? If I'm using dumped, at least use the name that starts with D.
Dumping syndrome?
Dubin Johnson, right? Okay. Now I'll give you an easy mnemonic. We have Dubin Johnson syndrome, right? And we have Rotters, right? 4 of them. Dubin Johnson syndrome or disease and Rotters. These 2 is conjugation problem. You cannot conjugate bilirubin. So you will always have unconjugated hyperbilirubinemia. And you inherit that. Now, in Dubin Johnson and Rotters, conjugation is not a problem. It is secretion of bile into bile ducts. In Rotter, it's a releasing problem. In Dubin Johnson, it's dumping problem. So dumping requires what? Active transport. So the transport is deficient. All of these are actually inherited. All of them are inherited. So here is secretion problem. How do we remember that again? Think of Dubin Johnson, dumping, Rotter, release problem, Crigler-Najjar, conjugation, Gilbert, conjugation. It has a G, I don't know, but you can think of Crigler-Najjar, C, children problem, Gilbert, adult, gentleman problem. It's partial, it's not going to occur. G for Jim, induced. The only time you should have jaundice or side effects of this condition is if you work out so much that you cause tremendous hemolysis. And now your liver cannot handle that because you have 50% less enzymes. Because it's a carrier state of the same enzyme. It's partial defect, not complete deficiency. You can conjugate, but not a lot. So when you're resting, no problem. As soon as you have stress on you, whether infection or workout or running or marathon doing, you will have jaundice. So G is easier, Gentleman syndrome. C is easier, Crigler-Najjar, children issues. But both of them are unconjugated bilirubinemia. When it comes to Dubin Johnson and Rotters, it's conjugated bilirubinemia. How do you differentiate? Again, in those 2 cases, when you do biopsy, for Dubin Johnson's, you will see dark granulation of hepatic tissue. You will see dark spots, D for dark. And that's because of increased storage of epinephrine granules within the hepatocytes. Don't know why, but that's what it is. So hopefully that helps you. You can differentiate them. At the end of the day, you have bilirubinemia that you inherited or hereditary bilirubinemia. 4 conditions comes to mind. 2 of them will cause unconjugated bilirubinemia, and 2 of them will cause conjugated bilirubinemia. If it's unconjugated, you have either Crigler-Najjar or Gilbert. Gilbert is in adults, Crigler-Najjar in children. Dubin Johnson and Rotter is only conjugated bilirubinemia, but then you have the issue of dark pigmentation of the hepatocytes versus normal hepatocytes. So easy. Okay? Okay. I'm done with these. What do I have left?
Oh, I found the thing. It's called cyborg spinal implant. This is what it looks like.
Wow, very. So they have to put it in, implant it inside.
In the spine, in the spinal cord. And it has low rejection, so it won't be rejected easy. And it's flexible.
It's crazy circuits. Look at it.
Yeah.
It's like neurons.
It's made out of gold.
Wow.
Yeah, it's gold and something else. I can't remember. But yeah, I thought it was pretty cool. They got a mouse to walk with. Mice and rats so far with it.
They start walking and everything.
Yeah. So it's called Edura.
Oh.
That's funny, right? Like electronic Dura.
Mm-hmm.
Yeah. They're hoping it
How
can.
small is it? Is this the exact actual size?
This is a person's finger, right there. So if that's their fingertip,
Mm-hmm.
that's pretty small.
Mm-hmm. It's impressive.
Yeah. And they came out with this. It's a heart valve that's gonna replace pacemakers in a way.
Oh, so it's almost like a circuit on the outside of the heart.
Mhm.
Wow.
And the way that this works is it can even predict when you're gonna have arrhythmia or like a ventricle tachycardia or something like that, and will
Yeah.
stop it. It will regulate heartbeat like that. So this is for high-risk patients of AFib and stuff like that. This is what they could give them.
Some pharmaceuticals are gonna hate these companies. Seriously. There goes amiodarone and adenosine out of.
Well, it'll be a matter of patients who can afford it versus insurances that will pay for it.
Mm-hmm.
And a lot of insurances would rather pay for medications cheaper
Yeah.
than a one-time big procedure might fail.
Mm-hmm.
If a
And
patient
then
dies, the insurance company can't make money from that anymore.
And then the patient will, once they get it, they might stop the insurance anyways.
Probably.
Mm-hmm.
I probably wouldn't stop the insurance because, I mean, you're going to need checkups.